but I'll show you every tip and trick that I know, or as many as I can. So with one wound, that's pretty easy to do. But anyway, just going through wound vacs in general and go through the basics of it. Really, it's indicated wound types are full thickness wounds, so stage 3 and 4 pressure or injuries, surgical wounds, dehisced surgical wounds, diabetic foot ulcers, venous leg ulcers. All of them are appropriate as long as they have surface area and depth to it. So the whole idea of using a wound vac basically is to promote granulation tissue. It's not a drainage removal device, although some surgeons like to use it that way, or some doctors do. So it's meant to promote granulation tissue. It works in 2 different ways. So one is mechanically. I take this, I fill it into the wound bed, I get a seal, I hook it up to the machine. At that point, what you're doing is decreasing the surface area. When it draws together, you have less surface area to grow granulation tissue in. The other thing it's doing is removing all the interstitial edema. So anytime you have an open wound, everything rushes through the area. Starting that inflammatory phase of wound healing, you get a lot of swelling and edema. So if we can remove that congestion, then we get better blood flow or better perfusion. At the same time, removing all the debris and exudate away from it into the canister instead of having it sit into the wound bed. So physiologically what it's doing, this foam is a certain porosity for a reason. It's about 400 to 600 micron pore size. These little stress pores actually pull that tissue and create a tension on the tissue and then ultimately the cell. So when we create tension on cells, they tend to turn on receptors in the cell wall and they divide faster. So that's how you get the increased granulation tissue. You're going to learn more about wound vacs than you probably want to know today, I guess. So anyway, that's kind of how it works, all the mechanics of it and the science behind it. It's all a proven therapy. We've had, I don't know, it's the most studied device out there. Been doing studies since the 90s. So that being said, contraindications, malignancy directly in the wound margin, because it has an effect on cells. It will have an effect on malignant cells as well, and will cause them to proliferate and do that kind of thing. So as long as there's no cancer directly in the wound margin, you can go ahead and use the vac. Other contraindications would be untreated osteomyelitis. So if you have a bone infection, or if it's just a wound infection, as long as you're treating the underlying infection, then you can use the vac. Okay. Necrotic tissue with eschar. So eschar present, it's really not a good idea to be placing a wound vac if the wound's not clean enough to do it yet. You're not to that point. So typically debriding that wound first and getting it ready for a wound vac is ideal. Although we see some high acuity wounds out there that come to you with a lot more slough than you would want to see with a wound vac. But CMS guidelines, just so you know, are 25% or less. So if you guys are documenting like 30 to 40% slough in the wound bed, really you need to have a plan in place to get rid of all that necrotic tissue. Necrotic tissue harbors bacteria and can cause infection, so that kind of thing. Other contraindications would be placing this directly over blood vessels or organs. That's kind of a no-brainer because it's going to actually adhere to those little structures and can either cause an active bleed, or if it's in a big deep abdominal wound, could potentially cause an enteric fistula if it's sitting directly on bowel. So we don't want that to happen. We never want to place this into a tunnel where we don't know where it ends. So obviously we don't want to draw on something that we don't know where it goes to, because it could be a fistula to an organ somewhere else. So other precautions: ligaments, tendons, bones need to be protected. So make sure that you're protecting it with something, some kind of a non-adherent contact layer. I do believe you guys use Adaptic, so if you guys use that or something comparable, Adaptic or Adaptic Touch. Regular Adaptic is a petroleum base. Adaptic Touch happens to be a silicone base, which is easier to use with a wound vac. I've been used and abused. So if you guys can pass this around, the key behind using a non-adherent contact layer with a wound vac is that it's wide mesh. So it has to be like a screen door. I'm trying to show the camera. So a wide mesh actually allows all that fluid to come through it. If you're using something like Xeroform or petroleum gauzes, they're a tighter weave and it doesn't allow fluid to travel through it. So those are not something that you want to use underneath a wound vac. It's something like this. So that's, you can touch it. It's a silicone base. It won't get on your fingers. So ideally, I like to use that one with the wound vac because it doesn't get all over the drape when you're trying to cut the drape, and then you have a problem with getting a seal around the outside of it. So silicones are better. There is another one out there called Mepitel. We sometimes see that used with a wound vac. The thing between, or the difference between using something like Adaptic and something like Mepitel, Mepitel has large holes. If you guys have ever used Mepitel before, it'll still pull that tissue through and you'll still get adherence of the foam. If you're trying to protect something, that would be, the better choice would be something like Adaptic. It's in the instructions for use to use that with negative pressure. Because of the way it's weaved, it covers more surface area. So that's why we use that instead of something else. So ligaments, tendons, bones you can use for that. Also for pain, that was one of those ways we were talking about alleviating pain with lidocaine and all that stuff. So lidocaine is kind of the last resort when you're trying to alleviate pain. What we typically do is just line the base of the wound with something like Adaptic so that we can kind of get that foam off easier. That's one of the ways to kind of alleviate the pain. Anything that goes in the wound obviously needs a doctor's order, that kind of thing.
I know. I wish we could do it too.
So another thing is bleeding. Bleeding is one of those precautions. We just had an incident the other day with a patient. Luckily, the staff was trained enough to identify that there was a bleed. So if you guys see or let the patient know that if they see frank red blood in a matter of 20 to 30 minutes in a canister, obviously you're going to see more sanguineous blood. But if it's bright red, this patient kept changing his canister, and all of a sudden he was getting kind of dizzy, obviously, because he was exsanguinating himself. So he called in, and that was a problem. So luckily the staff knew that to kind of identify that problem. So make sure your patients know it's just a precaution. Two different types of foam we use. 98% of the time it's granny foam or black foam. Basically this is a polyurethane surgical grade foam, right? So it's hydrophobic. It wicks everything right through it. It doesn't retain any moisture. That being said, there's a 2-hour window for this, so if the machine is not working, we don't want to leave this foam in this wound longer than 2 hours in a 24-hour period. It's a nice warm environment for bacteria to start to multiply and start to grow. So always have a backup plan, kind of a benign dressing like a wet to moist saline gauze and a cover dressing, just to make sure that if you can't get out there, hopefully somebody in the home is able to remove that dressing and then replace it with a gauze dressing until you can come out and fix it. So 98% of the time this is the one you want to use. It provides or promotes good granulation tissue because of the porosity of this foam. You guys familiar with white foam? So most people are in home health. I did home health for a long time too. We get the majority of wound vacs, so that's the way they come out of the hospital. So everybody's pretty familiar with this stuff. White foam, polyvinyl alcohol foam. It's a denser foam, so when you're using this in a wound, make sure you leave it in a single layer. Black foam always covers white foam, no matter how much of this you're using. Whether you're lining this in the whole entire base of the wound, you still put a little wafer of black foam over the top. And the reason that is these pores are a little bit smaller. This little trackpad right here has a hard time reading the pressure when it's sitting directly on white foam, so always put black foam on the top. But mainly we use black or white foam for tunnels and undermining because of its tensile strength. So I have a general corny rule. Basically, it's if there's no end in sight, use white, right? So if you can't identify or assess the base of this tunnel, probably not a good idea to put something like black foam in there because it has a tendency to break off in the base of it, and you can leave a little tiny piece behind. So seen that happen all too often when we're using too much black foam in those areas. But if you can get it back, the best thing to use is black because it promotes that good granulation tissue. So this is just for safety. Whenever you're using white foam, the initial application, take it, cut it blunt like this, measure your tunnel, take the back of your Q-tip and kind of stick it into the foam and then guide it into the tunnel until you reach the base of it. Leave it there for that dressing application. Every sequential application after that or every dressing change, cut it more like a thinner or like a pencil in the top of it. Do the same thing, fill it all the way to the base of it, or you're going to pull it back about 1 centimeter each time. So fill it to the base and then pull it back. So what you're trying to do is allow that negative pressure to pull the tissue together at the end of that tunnel, hopefully adhere it together. So one other thing to show you guys that you guys maybe have not seen before, it's kind of new, but we do use Prisma every once in a while for problem tunnels that aren't healing. We're not going to use this every time in a tunnel. If you guys are familiar with Prisma at all? So Prisma basically is a collagen. Collagens are the matrix that kind of bind the wound together, right? So if you want to pass that around and take a look at it, this is not an alginate-based collagen. With Prisma, it has ORC, which is oxygenated regenerated cellulose. I can't even remember how to say that this morning, it's too hard. So, but basically what that component does is it doesn't allow those MMPs to kind of break down that collagen in the wound bed. So it lasts a lot longer. And with the Prisma, you get an added benefit of the 1% silver. So silver is a broad spectrum antimicrobial. So how we've kind of treated this.
Is that the same as Puricol?
Different than Puricol, yeah, because of the ORC. So there's actually a bunch of randomized control studies on Prisma, so you can look all those up on our website. Actually a proven therapy as far as using collagens in wounds. The reason I show this to you with the wound vac is sometimes it's impossible to get the white foam down to the base of the tunnel. So with Prisma, or just regular Promogran without the silver, we can take this, introduce it down into that base of that tunnel, and then take the white foam and follow it behind just to keep the tunnel open to facilitate drainage, and then cover it with black foam. You don't have to get Prisma back. It bioabsorbs. It absorbs right into the tissue. So it'll be a nice wound filler down at the base of that. By the next dressing application, it'll be completely absorbed. So then you just add more. So the reason that we do that, sometimes we have these wounds that heal up around like this, and then we have this tunnel that just won't go away, right? You've all seen that before. So using something like this with the collagen and with the silver component all together, it tends to react and have a better outcome with tunnels. Like again, it's not used all the time, but it's actually a good way to treat those problem tunnels that you can't close. You guys have any questions about any of those? I'm just rambling on. What I tend to do. Ramble on. So other things that we can use to help us maintain really good seals are something like ostomy rings, ostomy paste, for problem areas such as wounds like this, where you don't have a lot of room in between that wound edge and the exit here, right? Sometimes it's really hard to maintain a seal right here. So the other thing what would be good for is feet. Anytime you have a foot, always have this stuff in your bag, because feet are problematic and they're really hard to maintain a seal. So skin prep is always your best friend. I don't care what kind you use, but skin prep always goes down first. Drape goes down next. But this in between, if I need to use something like this, you guys have never seen or used this stuff before with a wound vac. So what these ostomy rings are, basically are a different consistency of a hydrocolloid. So it will retain some moisture or draw some moisture. So if you're having problems with maceration like heels and stuff like that, sometimes lining this around the outside of the heel will help with that maceration on the outside of it and help you maintain a seal. But the majority of the time you're going to use this stuff when you have moist wounds, so moist wounds in groins, perirectal areas, next to labial folds. We've all seen all of those different types of applications. They're very difficult. In the home health setting, we get really high acuity wounds these days. Sometimes we don't want these patients in the home, but that's what we have to do. They would be better off in the hospital. But placing something like this after we put skin prep down in these cracks and folds, it's just going to kind of level the playing field in these moist, kind of wrinkled areas. So taking something like this and going around this entire wound will be beneficial to help maintain a seal a lot longer. Have you guys used this stuff before? Some people have, but yeah, no? Not with wound vacs?
No.
So it really is helpful if you guys have some of this and you're having a problem keeping or maintaining a seal.
But you can't keep it in your car all summer.
Yep.
Even the tube will become a solid mass.
That is true.
You can never get out of the tube.
The R's are off.
Yeah. Doesn't last well. Sorry.
So basic components to this dressing kit. You get a piece of foam, whether it be small, medium, large. You guys have the ability to get wounds or dressings that are already pre-cut, like a spiral. So sometimes it's beneficial. In these books, it has a list of all the dressings, so take one of those with you. My favorites are the Simplace EX dressing, which is already pre-cut for you, and you just kind of unravel it into the wound bed, which is nice and easy. The Bridge XG dressing, that helps you kind of bridge somewhere else. You can like them or not like them. A lot of people have done wound vacs for a long time, like just to make their own bridge, and it's fine. So, but some of those other dressing applications are in there. So main components: foam, Drape, it's numbered for you. So side 1 goes down first. If we can count, we can probably do this. So side 1 goes down first, that's the sticky side. Then number 2, this backing comes off. Basically this is just a stabilizer to make sure that it doesn't wrinkle up in your hands. And then the blue part comes off. I can show you pictures on how not to do draping of a wound. If you'd like to see those after, I have some really funny pictures that kind of blow your mind what people do. The most important part of this really is the Trackpad. There are other negative pressure wound therapy devices out there. They use single lumen tubing, which is what we used on our first wound vac that came out. The problem with single lumen tubing is when you have fluid, and the longer the tube, the more pressure you kind of lose and drop, and it's not completely accurate. So with track tubing, if you look at it, it looks like a piece of licorice. So there's a center lumen that draws all the fluid through. There's 4 lumens on the outside of that that actually communicate with the software and the pump and maintain an even pressure all the time. So that's why that machine makes little blurping noises up and down, that kind of thing. So how it measures pressure is by this right here. So the majority of this little part inside here needs to sit on black foam or on some type of foam that you're using. So it measures pressure by these little lines, and especially these 2 little holes right here. So if we're cutting a little tiny hole or a crisscross in this and trying to put this on, it's going to alarm and tell you there's an occlusion because you're blocking all of this the way it's trying to measure the pressure. So basic dressing application really consists of this. Protect the peri wound at all costs. Never have foam directly on skin. That is a super no-no because it will just draw the blood to the surface. All this drainage on the outside of this will just macerate the outside and eventually just work it down. So always protect. Skin prep goes down first. The second thing I would do if I needed to would be add something like an ostomy ring. It's not always necessary, but if you're having a problem maintaining a seal, that may be something you want to do. I think the easiest way to do this, draping, and using this drape, because this is the hardest thing to get used to if you're not used to doing a wound vac, is cut it in half and then always cut towards the blue. Because if I cut this off right here, then I don't have my number 2 to pull off, which we've all made that mistake before, right? So, yesterday?
Not yesterday. No, yesterday was great. But it was with the lesser quality product.
Oh.
Just saying.
You're not naming names?
We don't say swear words like that.
You're not naming names.
Oh, no.
So taking this is just a good practice. If you look in the guidelines, really, this is not necessary as far as the guidelines go, but it's a good practice to do this so that you protect the peri wound around the outside of it. So you can take this, go around the outside of it, lay this on the wound edge. You can do it in strips. Do your 1-2 blue right here, and just keep going, continuing around it. You do it that way. Another way to do it, potentially, is just taking this and tracing this out around it, and then putting it on that way. The other way would be the easiest and fastest way, which is typically the way I do it most, is by taking this. The easiest way to manage this drape when you cut it in half is just pull it apart like a band-aid, so that way you know kind of where it's going to go. Just take it, cover the whole thing, like so. Do your 1-2 blue. So that'll come off. And then take a pair of suture removal kit scissors, because they're kind of rounded on the ends and they're not really super sharp on the end. And just kind of put tension on the drape and just go around the outside of this. It makes it nice and quick and easy. If you're not comfortable doing it this way and the patient's watching you and you're shaking, it's probably not a good idea to do it that way. So then just roll this back like that. Now you protected the whole peri wound. So if all you had was medium foam, which is typically what they come with when they come from the hospital to you, so that's just kind of the benign dressing that they send, because it kind of fits into all the categories of what we need to use it for generally. I usually take this, cut it in a big circle or a big spiral, just like the ones that come to you like that. It's just easier to fill a large space. I'll cut that out, lay it aside. Take this with your gloved hands, which I don't have gloves on. So as far as video is concerned, I would have gloves on. So take that, roll it up into a noodle like that, then leave this piece for later. Cut a piece right there. So I do have bone in this wound. So just to kind of give you a tip or a trick for using adaptic in a wound, we've all taken this little tiny piece and tried to cover just the bone or the ligament or what have you. It's really hard to find sometimes when you leave this in the wound bed when you take this dressing down. So you're in there with a Q-tip trying to dig it out or what have you. So documentation is super important when you're using, well, with anything really, but especially using a wound vac, because we need to know how many pieces of what we put in here. So this is just an easy way to put adaptic into a wound, and leaving a little pull tab out here so you're not going to lose it. This has no effect on the seal because I'm going to put the drape way out past it. That way when I remove this dressing, then all this comes with it, so it's easy to find. So for wounds like this that are circular, by all means just cut a circle. If they're shallow, you can cut this and fillet it in half and make it thinner. So it doesn't have to be this full thickness the whole time. But for wounds like this that have a little bit of undermining and what have you, just take this, roll it up in your hands. Again, if I can get away with using black foam, that's the best. But when I cut the foam this way, I tend not to overfill it because we never want to pack this foam in there because we want that whole thing to shrink down. We want the tension. So if I do it this way, I can just lay it back and forth across the wound. Instead of trying to be a master sculptor and cut it the perfect size of the wound, you'll have pieces of foam flying everywhere. So this is just a little bit easier way to cut it. So cut yourself some little pieces. This is your third hand. I did home health for 12 years. I know we don't have help holding stuff, and this stuff is going to want to come out at you when you're trying to get a seal. So the easiest thing to do is just take it and start this piece like so, and hold everything where you want it. Seems like an extra step, but it's worth it. So how much foam is enough foam if you're looking at this? Basically, it can be higher. You don't have to stuff it in here and make sure that it's in there. So at the end result, when this draws down under negative pressure, you want it to be somewhat level. So if it's not, and you have a wound vac on for a couple of months and you continuously don't put enough foam, what's going to happen to that, if this is concaved all the time, what's going to happen to those wound edges, you think? Yeah, so they'll form what's called, my favorite word, an epiboly around the outside of it. Basically it's just a chronic wound edge around the outside. Once that happens, then the wound thinks it's healed, so it will never come together anymore. It'll come this way as far as granulation tissue, but as far as your length and width, it'll stop. And we have to do something else to alleviate that chronic wound edge, which is typically calling somebody out there to do silver nitrate around the edges and all that kind of different stuff. You guys have any questions so far? So this part is basically getting a seal. What you don't want to do is take this and pull and stretch this. You just want to lay it over the top. Just remember, positioning your patient before you do this is super important. So making sure the patient's in the right position to do it. Some of these wounds are really difficult to seal, especially if you're trying to tuck this into folds. So abdominal wounds and stuff like that, make sure they're laying kind of flat and kind of stretched out. For wounds like this guy's going to be kind of all folded over, and you're going to be trying to tuck the drape down inside there. That's not very effective. What you want to do is level it out, make it kind of taut, and then you'll get a better seal that way because you'll have more room for for flexibility with the drape. So taking that, we can just lay this over the top and just kind of press down on it. And we start that. If I didn't quite make it and I didn't have enough over here, we can always add more. So it's not a big deal. So the hole size is super important. How big should the hole be? Anybody know?
Size of quarter.
Quarter. So it says like 2.5 centimeters, which is the size of a quarter. I usually tell all nurses the size of a $50, which is basically the size of this right here. The reason being is no nurse likes to cut a hole in their beautiful dressing that they just did, so it ends up being about like the size of a pea and not big enough. So if I tell you a $50, it ends up being like a quarter, like it should be. It's always smaller. So take this, pinch and pull it. Attempt not to cut the end of your glove off. Or your finger, yeah. So for bony prominences, that kind of thing, on a sacral wound like this, I would never want to put a drape or a track pad right here, obviously, because they're going to be laying on this. I've seen it all three ways. I've seen people put it there and then say, oh, maybe I can put some foam underneath here, and that'll alleviate that. No, it won't. It's still going to add pressure. And then I've seen people put it this way thinking that there's not going to be any pressure there, and that's just not okay. So we take it and we need to bridge, right? We can bridge multiple wounds together if I had multiple here and use one machine. The only key thing is protecting with drape in between there so that you can run the foam across it. So we never want foam to come in contact with intact skin. So draping first, and I can bridge this out like so. So just to show you, I forgot to get this one done. Bear with me a second. So if you guys have never seen a bridge before, this is what a bridge dressing looks like. So this bridge dressing already is made for you, so you don't have to make your own. So taking this bridge from this point, using this one, basically this right here is all adhesive all the way around this. This foam is exposed. At this point, I could take that backing off, place it right here, and then now my bridge is already made for me. So the reason that I like to use these on sacral wounds or any wound like that is because we all know what adhesive does to skin when you're taking on and off 3 times a week. This is less irritating. So that's one of the keys behind that. And it's a little bit faster because I can take this. If I need to make it shorter, I just fold it in a Z, just like that. And then I can make it shorter. Then I can just kind of take whatever. In the dressing kit, it actually has little perforated strips in there that you can kind of hold it in place with. So that's a bridge dressing. The backing on this basically is just a surgical grade wood pulp. All it does is absorb sweat, that kind of thing, and moisture. So this is already made for you. But if I don't have that, which 9 times out of 10 I don't, then I need to make my own. So anytime you're bridging or hooking foam pieces together or even using multiple pieces of foam in a wound, always make sure they overlap each other so they don't pull apart. Take that drape like so. And we can cut this piece of drape down a little bit. I can cut myself another strip out of this. And again, see how this is going to be hard to kind of get a seal on, especially if they're laying over and the patient's moving around, which 9 times out of 10 they are. I can just kind of put this and hold this where I want it, so it's making sure that it's staying on top of that little piece that I put down first. Then I take another piece like so and go over the top of this. All I'm basically doing is providing or making a channel for fluid to travel through. So as long as all of this is sealed, you have equal pressure throughout the whole thing. So it's still going to do the same thing in the wound bed, but it's just going to pull the drainage from here and pull it out. If I was doing multiple wounds, I could have bridged this over here and then bridged it to somewhere else. It doesn't really matter. So at this point, I can cut my excess off If I was actually doing this on a patient, this doesn't give me enough room. But bridge this all the way around to the thigh. Don't bridge it over to another bony prominence because they're going to turn and roll on it and lay on it, or up here. So for abdominal wounds, especially lower abdominal wounds, if you have a wound down here, they're going to be sitting up at some point, and this is going to be folding over. For one, it's uncomfortable. For number two, it doesn't measure pressure correctly when it's sitting like this in a fold. So you want to make sure you bridge it over to someplace semi-flat to help you. So at the end of this part, what I usually do is take this, fillet it in half, and cut like a square, and I just cut the corners off of it. And I provide a little pad for this disc like this. It's just a good practice, you don't have to. A lot of people would just take this and set it over that foam. The reason I don't like to do that is because this is still plastic and it's underneath negative pressure for an extended period of time. If you guys have ever taken these off before, some of these elderly populations, they have pretty frail skin, and this will be leaving a big indentation where that track pad was, and that's not okay because it could potentially cause another pressure area there. So I usually take this. This is 1-2 blue as well. Then I stick this to this and flip it over, and then attach that foam to that foam, and then place it down like so. So that blue part peels right back towards the tubing. And this is my last OCD moment, promise. So what I do normally is take this and then pinch it around the tube. The reason I do that is just gives it support. Really, as far as the guidelines go in the book, and if you're doing it by the book, I don't have to. This is really a done dressing. You're all done. So if you miss this part, it's okay. But I take it, pinch it around it so that if this gets pulled on or tugged on, it gives it some support right here. And then sometimes, very infrequently, we'll get a little leak right around this track pad, in the summertime especially. So I always tend to want to cover that up and make sure that it's sealed off. So as far as patients go, or family members, or what have you, dressing changes are every 48 to 72 hours, so typically it's a 3-time-a-week dressing changes if you're writing an order. I used to write it just for 3 times a week instead of writing it for Monday, Wednesday, Friday, because then you're kind of tied to Monday, Wednesday, Friday. So you can do it differently. Canisters change once a week or when it's full, or if it has an odor, or if it's alarming and saying that it's full and it's not, it's still never going to work again. So just go ahead and change out the canister. This little guy in here basically is a I'm trying to think of the word now. I can't remember.
Coagulant pad.
Pretty much. It's kind of like the stuff in a baby's diaper. So pretty much when it absorbs the fluid, it'll explode in here. So let your patient know what that is, because sometimes they think it's coming out of their wound when they see that stuff explode in there. So this goes in, pops in place. I take this and push and twist. So if we're troubleshooting, if we're having leaks or something like that, always start with your canister to make sure that it's in. Then I check this connection next, just because sometimes it gets cracked or what have you, just taking it on and off. And then go down to your dressing. So every one of these canisters has a cap that comes with it, so save one of the caps and put it in their little bag that they use to carry this in. If you're trying to troubleshoot something, sometimes it is a machine's fault, but because it's never your dressing, right? Never. So put the cap on it and then turn the machine on and it should work fine. If it's not, then there's something wrong with the machine. If not, then there's something wrong here, but that's never going to happen.
I'm having a problem with my patient's canister. It always gets stuck, and it's so hard to
get off.
Yeah.
Some of them are like that. Sometimes it's just a mold. So if you ever have that problem, call one of us and give us the lot number off the box, and we can kind of send in that complaint. And sometimes maybe it's a bad batch of canisters just from manufacturing. So it happens more often than not, or
Yeah. For the third time.
I've noticed, like, when it's like the brownish color canister with the tubing, it doesn't work as good as the clear one.
they're
Like,
probably
I've always had
older.
problems with, yeah, I've always had problems with those ones. with it not fitting right and with it like not.
Because the shelf life of these are a long time, so they're sitting around for a long time probably. So yeah, if you give us a lot number, they'll replace all your canisters for you if you need them, for sure. So this is your power on button. Press and hold that for a second. Charger goes right here. When it's charging, this light will be on. When it's amber, it's charging. When it's green, it's fully charged. I suggest when the patient's home doing what they're supposed to do, which is offloading something, depending on where the wound is, which they never do. But just leave it plugged in so that way it'll be charged when they have to go somewhere. So the battery life on this, I usually say about 6 to 8 hours, and usually it's more, like up to 10 hours. Just depends on how hard it's working, how big the wound is, how much exudate you're pulling off. So if the machine is working harder, you're going to have less battery life, obviously. So turn that on. That little screen right there was just asking you if you know what you're doing, so hopefully you do after this. There's 2 different modes to this machine. There's clinician mode and patient mode. So when it comes to you, it should be on clinician mode. This gives us the ability to change any settings. This machine will always come to you at 125 millimeters of mercury negative pressure. It's kind of the gold standard. The reason that is back in the early 90s when they were doing studies, they actually measured perfusion on swine, and that's where you got the best perfusion. So that's why it is always that way. We could increase it and decrease it just depending on where the wound's located, how big it is, how much exudate. When you're using white foam in a wound, the guideline is don't go less than 125 because it has a hard time pulling fluid through it, and you'll get a pooling of fluid in the base of the wound. So if you're using a lot of white foam, I would probably suggest to turn it up to at least 150.
And Jeff, what is the max you can use?
I'm sorry, it's 200. That's the max it'll go. And the reason that was, from all the studies, they actually tested it all the way up to 400 millimeters of mercury negative pressure. And what that did at that point was just cause those little capillary networks to kind of close off and then shunt blood away from everything. So,
and Jeff, the pressure is the doctor's order, right?
Correct. Yes.
So.
It's always going to change. Everything's the doctor's order. Except for the stuff you use on the outside, which you still want it in your order if you're using something like this, just because then you know how to order it and how to get reimbursed for it and all that stuff. So basically, if I needed to change anything, I would go into therapy, next, settings, and here's my pressure or whatever I need to change. So continuous is typically what we use. Intermittent is actually better for perfusion as far as pulling that blood through the area. We don't really use it in home health just because it's an on and off. 5 minutes on, 2 minutes off. And it's really annoying for one, and sometimes it can be very painful and they don't tolerate it very well. So generally continuous is what we use. So pressure here, once I push that button then I can adjust my pressure for the doctor's order back and forth. So okay here, after I'm done setting everything. The other thing that I wanted to show you in here, which is a good thing to know, is therapy, next, and then you'll see what's called history down at the bottom. So if you have somebody that's not using the machine correctly, or they're shutting it off and going to the movies or going to the store, or sometimes at night it's really kind of bugging them and they'll just shut it off and they won't tell you. So if you see a wound that's nasty and macerated, there may be something going on there. So you can go into the view history and it'll tell you all the dates and times so you can see the gaps in time on the therapy. So shouldn't really be gaps in time unless you knew you were changing the dressing, and it takes you, 30 minutes or depending on, or an hour depending on where the wound's located. So that, turn my on and off button. Make sure your patient knows, take your hands and go around the dressing, make sure you got a good seal. This should be drawn down like a raisin, like so. So make sure your patient knows what it looks like when it's functioning correctly. That's important, because if this is kind of bubbled up and kind of hanging off and the machine's still going for some odd reason, which is not very often, but it'll usually alarm and tell you. But sometimes for some reason it seals itself off right here and then it'll not be working. So make sure they know what it looks like when it's functioning correctly. This right here, if I've missed something when it draws down, I probably wouldn't do anything about that until the next dressing change. But if I missed a big chunk in here, all I got to do is stop the therapy for a second, cut a slice in here, and then add another piece and document that, and then cover it up and patch it. So fixing leaks, so on and so forth. It's not a really good idea just to have them keep putting more drape because we already have a leak situation and there's fluid and drainage out on the skin. So find out where the leak is, peel it up, cut it away, clean it, dry it, put more skin prep down, and then put a patch on it.
And I usually use skin prep around the outside in case there's any micro leaks.
Yes, you can. You can go around the outside of this. I just don't suggest you put skin prep over the top of this because all you're doing is making this more occlusive than it already is. So then it's going to sweat underneath the drape. Good point. So as long as this is down in the green, we have a good seal on the seal check part of it. Never tell the patient that it should be completely silent, otherwise you've ruined it for everybody else following you. Never done that? So they won't. So if I need to go to patient mode, I used to just switch it to patient mode. So anytime I have a question, I hit the question mark in the corner. Then I'll see a little thing called patient mode. Then I hit OK. And now they only have the option to either start and stop it to change their canister and then turn it back on right here. So they won't accidentally hit all the other buttons in here. There's a lock feature right here. Basically, it's just a screen guard. It doesn't completely lock it out. But that way, if they grab it or what have you, I suggest keeping it in the case. Because when it's in the case, it's usually hanging the right way. And there's a big, nice, solid piece of plastic right here that's going to protect the screen in case it gets dropped. So this will sit in here and slide in like so. That way it's all protected. One thing I did want to show you with feet is how to create a seal and cut the drape. At the end, when I have this all done and ready to kind of create my seal, you guys may already do this, but the group that I saw yesterday, they didn't. I've never seen it cut like that before. The majority of them didn't. So take a piece of drape. Let's just pretend for a second, because nothing sticks to this foot, obviously, so I can't do the whole thing for you. But taking this ostomy ring, going entirely around the whole outside, if you roll it into a noodle, go around the outside. That way I don't have to pre-drape it. If I line the whole outside of this wound with something like this, then it'll actually, that is my pre-drape. I'm done. So putting it underneath here, filling it with foam and bridging it to the top, what have you. But taking this for the last final seal, folding this in half, cutting this kind of like an hourglass so that it looks like that. Taking this part right here and pulling these back carefully so they don't stick to each other, and then folding it back on itself. Then I take this in between the toes and then I let it relax. I create less wrinkles this way. I found that works pretty good. And take all these off, and then take your number 2 off. And then I put one more piece of drape this way and a piece of drape this way, and then it usually seals up pretty good. Because I have all that Econ ring and all that putty underneath these, you can just press around the putty, and it's actually going to help you create a better seal that way.